The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
Well, hello again, and welcome to the Pediatric Lounge. This is your host, Dr. Herb Bravo, and with me is Dr. George Rogo from Long Island. Today we have a phenomenal episode, but I will warn you, the stories in this book resonate with many of us as physicians and the experiences that we have had at the hands of hospitals and hospital administrators. So it is a difficult topic, but one that must be addressed, must be heard, and must be shared. Our guest is Dr. Wendy Dean. She is a psychiatrist, and she's written a phenomenal book called If I Betray These Words. Please buy her book, listen to it on audio, because it's something that every physician in North America needs to be aware of before they finish residency. Enjoy the show. Good morning, George. It's great to see you. It's another Tuesday morning.
Yeah, how you doing, Dr. Bravo? Today we have Dr. Wendy Dean, and her topic today is going to be If I Betray These Words, the Root of Physician Moral Injury. It should be a very interesting topic. A lot of the words that we're going to be speaking today are coming right out of her book, If I Betray These Words. We've read these books, and it's a really, really good read.
Dr. Dean authored a wonderful book, If I Betray These Words, and the premise of which was first teased out on a stat article called Moral Injury. She has made her research focus and her work focus to understand what is ailing the American physician. Dr. Dean, welcome, and we're so honored to have you on the podcast, and congratulations on such a great book.
Oh, thanks so much. It's a pleasure to be here, and thanks for your interest.
We always start with the same question, but for you it's a little different. In your book, you describe how you fell in love with a pediatrician as a very young person, shouted him around, and that was where your interest for medicine began. But you didn't become a pediatrician. Why not?
Well, I think a lot of us like pediatrics as our first introduction to medicine because it's what we know as kids, as teens in high school. But what I realized when I got to medical school was that there are so many other specialties in medicine that I think suited my personality better. I'm impatient to a fault. I started residency as a surgeon and did that for 3 years and then realized that I had too many other interests in life and that I wouldn't be able to devote myself to surgery like I knew I should. And so I ended up going into psychiatry.
You went into psychiatrist because of the relationships. That's what really, that is the joy of practicing medicine. Even
It
if you're
really
an
is.
orthopedic surgeon, their relationship is at some point more important than the hip replacement.
Correct.
And you describe just a beautiful story in your book about how you came up with the title of the book. How did you come about?
So my publisher, Steerforth Press, was amazing to work with. Part of what was so amazing was they never gave me a deadline for anything. They just said, we want this to be the best book it can be. So write the book, and when it's done, it's done. But then it started becoming clear when it would be done, which meant we had to start meeting deadlines. And the title of the book was the first deadline I had to meet. And it was 5 days away or 3 days away. It was very short. And we hadn't talked about it at all. And so for one day, it was probably a solid 5 hours or 6 hours. The publisher, my developmental editor, and I were going back and forth about, could it be this title? Could it be that title? What about this? What about that? No, we don't like this word. We don't like that word. And by the end of the day, I was fried. And I said, okay, I just need to go back. I'm losing sight of what this book is about. So I need to go back to the central focus of the book and sort of the central thesis. So I started reading all the different oaths that clinicians take. And I read the Oath of Maimonides, and I don't even know how many translations of the Hippocratic Oath. and the World Health Organization, all of these. And they had all the similar themes, right? That were meant to revere our patients, revere our mentors. We shouldn't be out for personal gain. But when I read the translation by Amelia Arenas, the last few lines sort of really struck me. And do you mind if I pull it out?
No, because
Because I want to make sure I get it exactly right.
It is so beautiful.
Yeah. So when I read these last couple of lines, I got chills and I said, okay, this is it. And it says, I pray that the attention I give to those who put themselves in my hands be rewarded with happiness. And in honor of the knowledge I've received from my teachers, I swear to care for anyone who suffers, prince or slave. If I ever break this oath, let my gods take away my knowledge of this art and my own health. Here speaks a citizen, a servant, right in the middle of my putting the final touches on chapter 6, which is about a physician who dies by suicide. It just struck me as this is what we're talking about. It's not just about what we do for a job. It's not just about these empty words and an empty promise. This is when we're asked to put something besides our patients first, it really gets at the heart of who we believe ourselves to be as good people and good doctors.
Yes.
I mean, those words are so powerful. So powerful. I'm going to level set a little bit because there's been a lot of discussions of burnout and moral injury and this and that. And I think that the terms are sometimes interchangeable. Some people use it in different ways. But I did like the way you sort of broke it down both in stat and the book. So burnout is a constellation of symptoms that includes exhaustion, cynicism, ineffectiveness, disconnection, and just I don't want to come back here, but I have to because I got to make the money to pay the mortgage. Would that describe it correctly?
Yeah, it's a demand resource mismatch. You have too much to do with what you're given.
I have a different term that I borrowed from the orthopedic surgeons, right? We're losing this battle. We tell kids not to play one single sport.
Yeah.
It's very bad for a child to only be a pitcher since the time he's 11, because he will end up with a bad elbow by the time he's 17 or 18.
Right.
The tennis player gets tennis elbow. The soccer player gets Achilles tendonitis. The person that types too much gets carpal tunnel. And to me, there's a repetitive stress injury in a very important muscle of the human body called the brain. When I'm being asked to do things like report BMI on every patient that I see 20 times a day, and I know that's useless information. No one's going to do anything with that. When I'm being asked to do an Edinburgh depression assessment on a mom at 6 weeks, I don't want to score it anymore. I'm tired. And I mean, the staff can score it, and then the insurance company doesn't pay for it. And if they send it to deductible, the mom's screaming at me. And if she does happen to be depressed, I got nowhere to send her.
Right.
But I got to do this over and over again, like if I was a monkey in an experiment. And to me, that's different than the burnout. Like, can't do this more. I'm tired. This is just every day my brain is being used in the same way and it's being injured. And then the third piece is what you describe in the book, which is the concept of moral injury, which is, if I get it correct, and then I'll let you expand on it, is when I know what my patient needs, but I don't have the resources, and society does not give me the resources to make that patient well. And that destroys me at a core.
The repetitive stuff is, I can see where they want these things for population health management, for good quality care, whatever it is. The problems that I think came about is the BMI and the maternal screening. You ask, there's a thing that needs to be done. Then somebody goes to a technician, an IT guy, and says, we want to do this. What does that guy do? Click another button, doc. It has to
More and
be
more
set
button.
up where it's automated behind the scenes, where the doctor doesn't even get involved. Like we set up our EHR that the BMI is automatic. If you think about it, it's crazy. You have the height, you have the weight, you have the age. The computer should tell you what it is. I should not have to input that information. I mean, it's just not one piece of data. Now they collect, especially in the hospital system and the adult medicine, there's many, many pieces of information, and the darn computers will give you a hard stop, will not let you go forward until you complete that task. And then it doesn't even tell you what you messed up on.
So,
Yeah.
Dr. Dean, going back to, so tell us in your own words what moral injury is and how that's affecting the American physician.
Well, I think you got it right. It's knowing what our patients need and being unable to get it for them because of constraints outside of our control. But it originated with combat veterans. There was a psychiatrist named Jonathan Shea who was working with combat veterans from Vietnam. He was treating them for PTSD and they weren't getting better. And he said, well, hang on. He's a good clinician. And he said, I know that these treatments work, but my patients aren't getting better. So rather than blaming them, he said, maybe it's something else. And he came up with this concept of moral injury. And he said it was betrayal by a legitimate authority in a high stakes situation. All three of those things had to be present. And then some of his colleagues, Brett Litz and his fellow researchers, expanded on that concept and said it's transgressing your deeply held moral beliefs and expectations. I think those moral beliefs and expectations for professional sense are the oaths that we took to put our patients first, right? What I think is really interesting is all of what you're talking about comes because with good intentions, we're trying to get all of the data that could be useful to help patients. The problem is we forget what the cost is for the people who are gathering the data. And we fail to ask them how it will impact them. We fail to tell them why we're doing it. And, we do what's easy on the IT side, which may be to have you calculate the BMI rather than having to put in a formula that automatically calculates it. The problem is that nobody is following you around to see how many clicks you're doing, right? And so I think if we just made this more of a negotiation rather than a declaration, we all might be a lot happier.
Yes. When you talked about the story about the research on the PTSD, I was reminded of a movie. I forget what the movie was, probably 10, 15 years ago, about, but they don't call them snipers anymore, but he was a sniper and he had terrible problems with PTSD when he came back. He had hit more targets than any other person in the armed forces. And when the psychiatrist asked him, does it haunt you that you killed so many people? And his answer was, no. What haunts me is that I didn't kill fast enough to help my guys stay alive. That's what haunts me. I could have done more for my people. And I think is what you described in that observation. His wound was the fact he wanted to do more. He wanted to keep the soldiers that were on foot patrol alive.
Right.
It's very powerful. Dr. Dean, you talk in the book about what happened to the specialty of psychiatry in the 1990s with the advent of HMO and how that's decimated the access to mental health in America. What happened in the 1990s?
Oh boy. Well, I think that if we want to talk about underfunding of psychiatry, we need to go back to the 1960s when we had, again, a good intention of deinstitutionalizing the treatment of the mentally ill. And President Kennedy signed in the Community Mental Health Act and said we should try to empty our psychiatric facilities. Great intention and a really great idea. But the problem was that we never took into account what it would take to set up the community mental health centers to be ready to catch all those folks who are coming out of our psychiatric facilities at the same time that we had to keep those psychiatric facilities running. So we initially, it would cost more. We didn't take that into account. So the community mental health systems never got sufficiently funded to be robust enough to do the treatment that they were being expected to do. And then when we closed the psychiatric facilities, that funding never got ported over. It just went away. And so we have systematically underfunded psychiatric care from the 1960s, so more than a half a century. When we got to the HMOs, we allowed them to carve out mental health so that the caps could be higher. It was an entirely different metric for how we took care of mental health and provided mental health care in the outpatient setting or the inpatient setting. For medical issues, there was no cap. There was, maybe $1 or $3 million of a cap. For mental health care inpatient, as an inpatient, the cap might have been 100,000. So, and that was a lifetime cap. And what that did, it was not only that, but it shifted care from psychiatrists. It drove psychiatrists into a very biological model, away from doing therapy and medications together. It drove a team approach to care so that therapists would be seeing the patients, the psychiatrists would be managing the medication, and it worked great if you were tightly tied together, if you worked in the same organization, or if you were very conscientious about communicating closely, it worked really well. But as folks got busier and busier, it got harder and harder to maintain that level of communication. And so care started getting fragmented. In some places, they still do it exceptionally well, but it takes a lot of effort on the part of the clinicians to make sure that happens.
So when you tell that story, it reminds me of something I hear over and over again, which is physicians should work at the top of their license. The American Association of Medical Colleges acknowledges that there's a shortage of pediatricians in the US, but that's not a problem because nurse practitioners can take over, which is what they said about psychiatry. Dr. Psychiatrists, work at the top of your license. We're going to make it absolutely unprofitable for you to do psychotherapy. And we will let a social worker with half your skill manage the patient, and you just be a pill mill doctor. That's all you're going to do. And that's what they're saying about pediatrics. We don't need a pediatrician. A nurse practitioner can do it. They're being disingenuous because the nurse practitioners start 100,000 here. And they can do 150 working for a specialist, working 4 days a week, no weekends, no nights. And so that's just, the way the world is. They're not going to stay in primary care. They're going to move over where it's a nicer job with bigger pays because they got families to feed like everybody else. And the reason I kind of asked you to tell that story is because the same thing is happening to pediatrics. 52% of the kids are financed by Medicaid, which has been woefully underfunded since the 1960s. Health plans are paying $40 for a physical. There's no way you can do a physical for $40 in the same business. We're being told that we can be replaced by mid-level. Well, if you're paying $40 for a physical, the physical is going to have to be not done or done by a coaching, wellness coach, a kid coming out of college with a 4-year degree. And already it used to be a problem to find pediatricians in rural communities or poor urban communities. Basically, because you could be a Black woman that's born in the ghetto in Baltimore. And if you make it through medical school and become a pediatrician, you're afraid to go back to that neighborhood and get shot. And you can't make money. So you move to one of the suburbs and you practice along with everybody else where your family's safe when you go home. And we've seen what's happened in psychiatry. Even if you have the money, even I'm willing to pay you $400 an hour, you can't find one. If you don't, great. Because right now, we are, where I live, we have a Noble Children's Hospital within 30 miles. In Richmond, we have MCV College of Medicine as a children's hospital within 2 hours. Children's National is maybe 35 miles down the road. And Hopkins is an hour and a half. When I have a child that needs a pediatric psychiatrist, it's a 2-year waiting list. So I'm very fearful that they're doing the same thing to the pediatric specialty that they did to psychiatry. And only the ultra wealthy will have pediatricians. And the rest of children will have no access to care.
So I think one of the challenges in this is that we really, as physicians, we forget that what we take for granted every day, the level of our training and why that's important, that it's not known to the public as a whole, to the public at large, right? So I feel like we need to do a better job of explaining to people why it matters to have a physician who is at least available, at least present, preferably involved at some level. Because even when you talk about well baby checks, there are things that get caught because babies can't talk and tell us that their vision is off or that their belly hurts, or, so I think it's important that we make it really clear what our training, a subspecialty, because otherwise it's this big black box that people don't understand. It's like expecting people to understand what it's really like to be in combat when they've never done it. You can't explain that. We all think we have an idea of what it would be like, which is entirely different. So when you've got two doctors talking, they have shorthand and they know what they've been through. Combat veterans talking. But when you try to explain it to people outside, I heard from a CEO who was a non-clinician. He was a CEO for a healthcare group, non-clinician, but he was not a bad guy. And what he said was, I was the head of this organization for 10 years, and I had no idea what physicians were facing every day, what their challenges were, and by the way, how risky it was for them to speak up.
If they speak up, they're considered disruptive as physicians.
Well, there's that.
I've been there.
That's you.
But and I think that's part of what he didn't understand.
Yeah.
Was how fearful physicians are to speak up for that very reason.
Yeah. Your chapters in beers and medicines highlights that, I think, a recurrent theme in your book, which is at the crux of the problem. Sometime before the 1990s, hospitals, physician practices were all led by, I'm going to say it, an elderly physician, because that seemed to be the way it was. You practice pediatrics, OB, psychiatry, whatever it was, for 30 years in the community. And people were, wow, you're really smart and you're good with people. And then you would become the leader of that organization. And you would hire people to help you do the stuff that you weren't good at. And some point, it changed. It's the MBAs that are, quote unquote, the leaders. And the clinicians are just revenue producing units. Why did that happen? And how bad has that been to the well-being of the U.S. citizen?
I think it happened because as HMOs and other insurance products got more complex, it became harder and harder to be a physician and to manage the business. Not that we couldn't understand the business, but managing the business got to be more than a part-time job. And so what we thought was fine was to bring in business experts to run our hospitals or our practices. And it still works. It still can work well if those business professionals work in concert with physicians. The organization can maintain the focus on patient outcomes, patient experience, the well-being of their clinicians, then it works really well. Everybody's doing what they were trained to do. And they're aiming for the same goal. I think where it becomes problematic is when the administrators decide, well, this is my hospital to run. I know how best to run an organization. I know how to run a corporation. And so we're going to run it like that. And they start dictating down. And they haven't been clinicians. They don't understand the pressures of clinicians. They don't understand how their decisions will impact clinicians because they don't, even though they might be well-intentioned, saying, this is the best way to keep this organization alive with these tight margins that we work with. They don't understand that changing a supplier might have significant impact on that clinician when they have a hole in their glove 3 times during a surgery, right? Just something simple like that. So the way to approach that is to try to get physicians' voices to be more prominent in the decision-making process, or to make sure that clinicians and administrators better understand each other's issues and problems and work together.
So in that chapter in particular, you allude to what you call EBITDA. It's a piece of trash. I call it the cash cows. The US-based hospital administrator that is not tied to a very strong physician will chase the cash cows and not worry about the quality and destroy the organization. And there is a lot of that. On the flip side, and we must own this because we can't really throw stones at a glass house when we have problems too. I've come into contact in my career more than once, and regrettably, pediatricians who, for profit, do things to children which are unnecessary and put them at risk. And as you alluded, when you take these powerful entities, because they are, I mean, if you lead a service in neonatology at a community hospital, you're bringing in revenue for that hospital. If you say you cannot have a kid who's a newborn for 10 days on IV antibiotics when their cultures are negative at day 3, because gent can make you deaf, gent can kill your kidneys, not to mention of all the other problems with putting IVs in newborns. You become a disruptive physician.
Whatever happened to first do no harm?
I'm bringing to this, George, is that we must admit we also have a problem sometimes. We must do better to self-regulate so that when a physician says this doesn't make sense, it's an open discussion. And I don't have to get administration to hire a $100,000 consultant company to come tell them what the OBs, every other pediatrician in town knows to get the problem resolved.
That's what
I'm happy to take the fall for it, because once I did this, it elevated a wonderful person that he just retired, that for 20 some years did great service for the community. But we should be able to speak up about these things in an open way without fear of retribution. And we should always have the best interest of the patient first, not our egos, not our pocketbooks. We all need to make money. I got a mortgage. There's some certain drinks I like to buy. They're expensive. I like to eat. My bike sometimes breaks down. I got to get it fixed. I'm not an heir to the Kennedy fortune or married to Mark Zuckerberg. I got to make money, but I don't have to be a crook.
Right.
And I don't have to do harm to kids to make money. I can make money doing good. So we have to acknowledge sometimes we're part of the problem, regrettably, but we are.
Yeah. So I agree with you. We aren't perfect. There's no sector that is perfect. And we're human, right? And I think that really highlights this, that we as a group are human. We have the bell-shaped curve of good behavior and bad behavior. I hope that the right end of our curve is quite thin and narrow, but we're there. And I think we do need to have the ability to speak up and to not fear for our own safety when we do. And I think, part of the other thing, part of the doing that is, which we don't teach people in medical school, is how to do that in a safe way. And it would be great if we could get to a place where we teach that more often. How do you work with a bureaucracy? Because 70% of us are now employed as physicians. By definition, every time you have a human system, there is a bureaucracy, no matter how small, it's there.
Mhm.
And so learning how to function within that bureaucracy is really important.
Absolutely. And the FAA has a wonderful program. It's been around for decades. If I'm the captain of Southwest and I have a near miss episode, I'm rewarded for reporting it.
Yeah.
I don't lose my license. I don't have to go to therapy. I don't need to get drug tested. It's like, what happened? Tell us what happened. Okay. All right. Is this happening at other airports? How often is it happening? How do we fix it? And they had the same problem. A plane crashed because the captain was such a jerk that nobody in his crew, including the first officer, was willing to tell him he was wrong. And he crashed the plane. So we could change to that kind of system, but we haven't. I don't mean to be political. These things just irk me. But, why do we keep asking physicians to do things that are not evidence based? For example, maintenance of certification. Wasted time and money takes me away from my patients. And there is not a single study that says I am a better doctor for wasting my time and paying these dues to the ABP so that their CEO can make $800,000 when the average pediatrician in Wisconsin is starting at $120,000. It is unconscionable. Why?
Well, I told you many times the reason that they're doing it's a money grab, one, and two, they have technology. So they spent a lot of money on expensive technology that they have to use.
Well, I want to know Dr. Dean's take on this. Why do we need to do it?
I was just talking with my husband about this last night.
Okay.
My husband is also a physician. Sorry?
Sabine?
Shervin.
Shervin.
Yeah.
Yes.
So again, I think the intentions behind it are good. The original intentions behind it to make sure that we keep up with our continuing medical education is a good thought, but I think it's gotten out of hand. It's gotten to the point where we're somehow feeling like we have to prove over and over and over again to, I'm not even sure whom, maybe to our peers, that we are good enough. As if repeatedly taking these exams is going to prove that we are good enough to keep doing the job we've been doing for the last 2 decades. And when you compare it to, for example, lawyers, they don't ever have to retake the bar. They do have CLE, but their CLE is a fraction of what we have.
Yes.
One might argue, well, lives aren't at stake. Well, I would argue with a lawyer, they are actually at stake because it's freedom.
Or the death penalty.
Right, well,
If they get it wrong, you're dead. And you might have been innocent.
Right. I do think that we do a lot of things in the name of patient safety that are really, whenever you bring up patient safety, it's very hard to argue it. But I also feel like at some point we have to go back to the evidence and say, is it, if we're not making a dent, if we're not better for it, should we keep wasting people's time and money? Or should we somehow shrink it?
Yeah. Political help. But as a physician, I know a lot of my colleagues who won't dare speak up in public. When they hear the term DEI, they feel like they're being called racist. And many of us have been taking care of very divergent populations. I've been doing it for 30 years. And I don't care what your religion is, what your politics is, what your gender is, what the color of your skin is. I've always said a hole is a hole, and if it gets infected, I fix it. How I got there infected is not for me to pass moral judgment. My job is to fix it. You got an infection, I'll fix it. You got a sinus infection, I'll fix it. You got an STD, I'll fix it. I'm not there to judge. And to a lot of us, it feels like when they say things like, well, if you're not a Muslim female physician, you really can't take care of a Muslim girl with an ear infection because you do not share her experience. I've been doing that for 30 years. I'm not a racist. Why do you need to tell me that?
Silence.
And I'm all
Yeah,
for
well, I
if
mean, I
you
think this
rather
is I think
if you
I
rather
think,
your daughter
um,
see a female physician and it's available because it's a checkup, great.
well, I think that's the whole point, right? Is we want to make sure that those options are available. And for a very long time, medicine has been a very white, very male practice.
So was America. When I came to America in
Uh,
1977, 80% of the people were white.
We're getting a little too political.
yeah, I mean, I think this
But
is
let me say something. I'm that white male pediatrician. When I started, it was a white male Jewish boys club. I was the first non-Jewish guy. All right.
Yeah.
My practice now, I see white, I see Black, Hispanic, Latino, Asian, you name it. I see it. I see no color. I see a patient. That's what you're supposed to see. I see the most expensive insurance, the Medicaid of Medicaid. It's an insurance. It's the same. That's how it has to be.
Right,
Well,
George.
I think
but the other side she's alluding to is right. Yes. If my mom, who speaks mostly Spanish, feels more comfortable with a Spanish speaking physician,
Yes.
and that can be made available,
right.
and he or she is qualified, great. But if she's in the emergency room because somebody hit her car, I just hope for the best physician. I don't care. I mean, I just hope it's a really good physician. I'll go
Right.
transplant.
And what we also hope is that even if they're in the emergency room, even if they're a physician in the emergency room, that they take into account that they're culturally sensitive to how she may perceive her situation differently than, for example, a 24-year-old white male. Right. So I think it's less about who we are as people, but that we can also empathize.
And I think that's you need to respect, whoever's in front of you.
Yep.
And I'm all for it. And in pediatrics, it's very easy. Today, pediatrics is 70% women, 70% another color other than white. So you can definitely pick whatever you want. I know that for orthopedics, that's not the case. But for pediatrics, we're there. The other one that really irks me is, and I'm sure your husband is really quite just as irked as I am, this DA new mandate that you have to take 8 hours or narcotics management to renew your DA license. I don't write for narcotics because I was taught in medical school that they're highly addictive and they're dangerous for people. And I only wrote for them when the government decided that they were going to use pain as the fifth vital sign. And if the patient wasn't happy with the amount of narcs you gave them, you got dinged in the hospital. Once I stopped doing hospital medicine, I haven't written for Tylenol with codeine, hydrocodone. I've never written for Percocet. I don't ever intend to do that. The only reason I keep the DA license is because I got to give Adderall, Ritalin, and that's it. I mean, not even the Prozac, the Zoloft. They're not controlled substances.
Yeah, all these things come from adult medicine as usual and trickles down to peds, and nobody bothers to break it up. So
the psychiatrist is not using narcotics.
Yeah.
The radiologist is not using narcotics.
Well, what they're doing to psychiatrists now, I've had this, you'll find this interesting. A patient that had ADHD and some anxiety, depression things going on, diagnosed by the psychiatrist, a little bit more than your general pediatrics part, right? The psychiatrist decided that she is no longer going to be doing in-person cases. She's only going to do Zoom. and she will only continue to write the Prozac, and she will not write the Vyvanse or the Ritalin anymore. You have to go somewhere else for that. I mean, it's one patient with one
Well,
product.
it's right, and it's trickled down. The problem
Yeah.
is that the opioid epidemic has now trickled down into all
Mhm.
scheduled drugs.
Right.
So the psychiatrist who's doing telehealth can't do the urine drug screening and can't do, the monitoring, et cetera. It's probably time to have a larger conversation about a pendulum that has swung too far.
Oh yeah.
Yeah. I tell teenagers today, and it's heartfelt. I tell them, please, if you see someone doing drugs, run from that room as far as you can. Because when I was a kid growing up in America, you could do pot. Not that I did it, but it wasn't laced with fentanyl. I mean, your parents might beat the bejeebies out of you because, that's what they did in the 70s when they found out that you're doing pot. Because, George's mom saw us doing pot. And she called my mom, and we were all in trouble at the same time. And everybody got spanked. But now it's laced with fentanyl. One wrong move, you're dead.
Yeah.
And I can't fix that. I'm not passing moral judgment. I'm just saying, if it doesn't come from the pharmacist, no Adderall that you buy from a friend, nothing. If it does not come from your pharmacist, do not touch it. You could be dead in seconds. It's a whole different ball game. But it's not the prescription drugs that are the problem. It's, this fentanyl-laced fake medicines that are being pushed around all over the country. And it is a real problem. It's costing, I think, 100,000 American lives a year. And then I have to ask you a question. It's a very boring question. But the person that asked me to read your book and invite you to the podcast is a fellow podcaster and a pediatrician, wonderful person in Long Island, New York. And she was very interested in what your thoughts were on the American Academy of Pediatrics statement on or guidelines of obesity treatment. And since you're not a pediatrician, they have recommended that every obese child go through a very intense therapy program by a specialist that includes 26, like a CBT program, 26 weekly visits of 45 minutes as the first step. Now, let's understand that there's 87 million kids in America, and 30% of them are obese. Just in the 3 counties where I live in Northern Virginia, there's 400,000 kids in the school system. So that's 100,000 kids. If you could, I don't know how much is the top that a psychiatrist can see in a week, but I doubt that you can see more than 6 patients a week if you're doing psychotherapy, because it's just exhausting. But if you could see 40 patients a week, you're helping 80 kids a year out of 100,000 that need help. And so what's the solution? And you're getting reimbursed. Some plans are paying $50 for the visit. So at the end of the day, you're taking home $40,000. That's not going to happen. So what's the other solution? Well, I call it the pediatric psychiatric model. You're obese, I put you in semaglutide. You're on it for the rest of your life. You'll lose your appetite and you'll lose your weight. It's just a medication visit. I'll see you once a month. Collect the $40. I can do it on the TV. Do you think the policies like this add to the burden and the moral injury that people are feeling?
I think when the policies are put in place without sufficient understanding of the bigger picture and the access issues, the insurance issues, I think it does add to the moral injury, because it just doesn't take into account what the realities of the situation are. So we're being asked to do something, but our hands are tied because we can't do it. Right. I feel like as you were talking, I was imagining what happened in psychiatry when similar things were happening. And there were too many patients. There weren't enough psychiatrists or even therapists. And yet people were in need. So we started doing group therapy because it was less expensive for insurers and it was at least something for patients. And I can imagine that starting to happen in this instance, but it's still not, I think people are still going to struggle to get access to that even.
Right. It's a penny wise, pound foolish. If you can pay now invest now in prevention and have a well-adjusted, flourishing, non-obese young adult in the workforce for 20 or 30 years, that's a huge win. And it's the only way that democracy is sustained, through education and the well-being of the young. In the book, you mentioned the House of God, which is a phenomenal book, but you only understand if you've been an intern.
Mhm.
And I think, like the House of God, I think every intern or medical student should also read your book.
The medical students and the interns and residents, they don't even know what that is.
The House of God.
Yeah. I get a student every month and I ask them, did you read this book? They don't know. They don't even know what it is. But actually, because it's too taken away from reality. It's from 20 years ago, 30 years ago. Medicine.
Yeah.
Now, the next chapter, the next one, the second book that's more of today. I forget, what was it called? Do you remember her?
Man's fourth best hospital.
That's Fourth Belt Hospital. Yeah.
Yeah.
That's more of epic and EHRs and systems and bureaucracies. That's more of today.
So I'll tell you a funny story.
Yes.
This book is because of Sam Shem.
Yes.
Yeah.
You
So
say
we
that
were
in your book.
sorry.
You say that in your book. You recount the story in your book.
We had dinner with him and he insisted. He knew about the conversation around moral injury. And he said, you need to write a book. And my first response was just to laugh and laugh and laugh.
Well, you did a great job. I mean, for a first book, you just hit it out of the ballpark.
Well, so I have to give credit there too to Steerforth Press, because the publisher, Chip Fleischer, said, I know your ideas are great, but writing a book is really hard. So I want to make sure that we get this story told really well. And he paired me with Rebecca Radding, who is a developmental editor. And she's the one who really pulled the book out of me in a way that was understandable to readers.
Wow. And so, like a good movie, you shouldn't tell all the stories or the ending. And I want people to read your book. But I do want to ask you to relate the story of Dr. J. Newf, because I cried when I read that chapter. What happened to Dr. J? Because he's one of us.
Yeah. So this story, I want to be clear that I wrote this story, I told his story, not because I wanted to sensationalize it, but because I wanted physicians to realize the seriousness of the peril that they can get into when they speak up. And Jay was a pediatric physiatrist. The way that his organization was structured changed after he was hired. And it went to a productivity model. He started having less and less time with his patients. He lost his call coverage partner. And so he was on call every night. And he started saying, this is not tenable. I can't see so many patients during the day and be on call every single night. I need call coverage. I need, these are complex patients. I can't rush through them. And the more he spoke up, the more imperiled he became, but he didn't realize it until he was in a closed door meeting, and was asked to either sign his new contract or he would be evaluated as a disruptive physician, or he would be evaluated. And he didn't see the peril in that. He thought that he didn't drink, he didn't do drugs, he didn't yell at his coworkers, so he would be safe, and he agreed to the evaluation. And the problem is the evaluation, if people look hard enough, they can find something. And with him, they declared that he was burned out and he needed a 10-week program to get better. But when he left that program, in order to keep his license, he would need to be in a monitoring program for 5 years that he would have to pay for himself out of pocket. If he stepped sideways for half a second, he would get reported to the board and probably lose his license. And he just found that to be an absolutely untenable situation. And a few weeks after he came home, he died by suicide.
That's very sad.
It's
Awful
tragic.
story.
It's absolutely tragic. He was a beloved member of his medical community with his patients and their families. It's terrible.
And he was one of us, George. He's a
Yeah.
pediatrician. Not only a doctor, but a pediatrician.
Many
It-
employed physicians. This is what
Wow.
happens.
Right.
It's a heartbreaking story.
Well, and it's a cautionary tale for
Yeah.
all of us that we aren't maybe as savvy as we hope we are, and we can't imagine the levels to which some folks will go to make sure that we are
Manipulators.
under their control.
The manipulators.
So, you know,
It's
I want physicians to realize when you start feeling worried, that's the time to call a lawyer and have them on your side.
yeah, and find another job or quit. It's easier to quit and then go on to another business model, another practice, or
Well,
something before you get to this, there's no hope.
well, I think that the hard thing for Jay was that if he left, there was no one for his patients. There was
Yes.
no one in the entire state.
Well, now that
For
he
his
committed
patients.
suicide, there's still no one.
I understand.
He
I
didn't see
understand.
it then. He didn't see that then. Sometimes the best thing you can do is to leave. And I'm talking about a bad marriage, a bad relationship, about a bad employee relationship. And almost invariably, we hear this story so many times in the podcast. Physicians leave an organization that is not driven by physicians, not driven by mission, and they go hang their little shingle, and they're taking care of the kids, and they're happy because, yeah, they need the money. Again, I have a mortgage, I need the money, but they're making money and doing the right thing at the same time, which is possible.
Yeah.
You have another wonderful story, and this one.
Oh, Herb, even before we go on to that, even in the book, you talk about the beer industry, how the big companies took over the microbreweries and put them out of business because of, efficiencies, because of cost, because of a whole
Right.
lot of reasons that sound just like medicine. But what's
Right.
happening now with the beer industries? The microbreweries are more popular than Anheuser-Busch or whatever, Budweiser, the big companies.
And they're
People
being
will
bought
go.
out again.
Yeah,
No.
exactly. The cycle is happening all over again.
They're being bought out again. All these
Yeah.
craft beers that are great get bought out, and then they lose their DNA.
Right.
You have another great chapter. I'm not sure if I'm saying his name right? Dr. Ray Robot.
Ray Brovant. Mhm.
And he's an emergency room physician. And the name of the chapter, Showdown. And there's a sad part to the story and a good and a wonderful side to the story. And then I'll tell you what resonated with me. What is the story in this chapter?
So Ray Brovant was the medical director for an emergency room. And at this hospital, it was owned by one of the largest hospital companies in the US. And it was staffed by a staffing company. So they had a contract with the staffing company. And the hospital and the staffing company agreed to this, wanted the emergency physician to be responsible for all of the emergencies in the hospital as well. And so they were covering all the floors, the adult emergency room and the pediatric emergency room. So there was a chance that they would have to be in 3 places at once. And all of the emergency physicians said, this is not tenable. This is dangerous for patients. And in fact, one day, that is exactly what happened. An emergency physician was on the floor taking care of an emergency, and somebody came into the emergency room, had a delay in care, and eventually died as a result of that delay. And at that point, Dr. Bravant had been sounding the warning for about 2 years and had been saying, it's only a matter of time before this happens. When it happened, then he sounded the alarm louder and he was ultimately fired. What he did then was to sue the company for wrongful termination. But in order to do that, he had to build a case. And he had started building that case years before. And the reason I told this story was because I feel like if you read his case, which is available online, it reads like a playbook of how to build a case in defense of yourself and your actions against your employer.
And he won the lawsuit.
He won the lawsuit.
And that's not the great part of the story, right? A multi-million-dollar lawsuit that he won.
Right.
I don't think the money was as important as the fact that he won, but I really am glad he stuck it to them financially. I can't hide my bad person in me saying, glad he stuck it to the man.
Well, I think what's even more important, there are a lot of physicians who bring these cases, and the cases take a long time. They take 4 to 5 years. I think his case took 4 years to finally come to an end. And what happens to too many physicians is at 2 years or 3 years, they're like, well, I need a paycheck. Like, I need to be working. And so they settle. And the problem with settling is there's no precedent. There's no case law that's built that other physicians can then use as a springboard. And so that's the part that I really love about this. I love the fact that he won a settlement, that it was substantial, and I love that he built case law for other physicians to use.
Yes. I'm going to share with the audience the exact same experience he had. I just didn't sue or get money from it. But when I was starting my career as a PTD and hospitalist at Henrico's Hospital, the contract was owned by the neonatologist. And it was a great hospital. We had a pediatric emergency room. We had a PICU. We had a level 3 NICU and a very nice pediatric inpatient ward. And the census of the NICU was going down for 2 years. And one of the 4 neonatologists decided to leave. And so they went down to 3. And that was good for them because it maintained their income. It was bad for them because at that time I was less than 30 years old, and these people were maybe 45, closer to 50. There was no way on earth that they wanted to be in-house every third night. So since they managed the peds hospitalist and ED service, they came up to us and said, oh, simple solution. You guys cover the ER, the floor. You hardly ever are going to be called to the PICU and the delivery rooms and the NICU. And we'll just be here for backup. We'll come in from home. And I said, no. What if there is a stat C-section, because you do high-risk deliveries here, and somebody in respiratory distress in the ER? Who do I pick? Who do I abandon?
Right.
God forbid somebody extubates themselves in the PICU, and before the PICU attendant comes in from home, or even into a child that I sedated to fix his lip, and I gotta leave him or her to run to the C-section?
Yeah. You know what? The people that make these decisions are MBAs, and they're going to, well, he's playing the odds, probability. What are the chances of that happening? But unfortunately, in medicine, it has to happen once to your kid.
Right. And it's part of a risk register, and there are dollar figures attached to the risk register,
Right.
and it becomes a cost of doing business, which is unconscionable to the rest of us.
Right. Yes. It's like United Healthcare. United Healthcare gets fined all the time for breaking the law. They write a check and they move on.
Uh-huh.
They don't care. They know it's going to happen. When they get caught, they pay, they move on.
Yeah.
And it happened again in the example I described before. The whole program I built in 1995 with the help of the community, because community pediatricians really built the program, was ended. There's no pediatric emergency room in that community hospital anymore. There is no pediatric inpatient. They've actually written a letter to all family practitioners and pediatricians in town to please not send their patients to the hospital for radiology because they don't feel that they can do that anymore. And the reason is because it's a mostly Spanish-speaking community on Medicaid. But this is a quote unquote not-for-profit. So what was the solution that the wonderful, super kind, super intelligent neonatologist that I told you about before and his group were asked to cover the NICU and the emergency room in case the ER doctor could not take care of a very sick kid. Let's say the ER doctor can keep the kid stable long enough. But what if you go to take care of a kid with COVID or RSV or influenza and you have an RSV breakout on your NICU? Or you give COVID to a mom that just delivered a baby. There's a reason why they stay isolated in their little corner of the, and it's for infection control because these newborns can't take infections. And as an employee physician or contract physician, you either help the administrators do what they want to do, or you're out of a job.
The problem comes about in the old days when you had the community physicians. They were on staff. In order to be on staff, you had to cover stuff. And then they tried that. I remember once with us in one of the hospitals where they lost their neonatologist and they said, your group is going to have to cover the delivery room. And I told her, no, we're not. And then they threatened you with privileges. And it's okay, we'll walk. And they didn't want us to walk because we were too big to walk. So they came up with a different plan. You know, you have to bully your way back in. Most doctors won't bully their way back in.
Well, I don't even think it's about bullying. I think it's just about
rights,
declaring our boundaries.
Yeah.
And to say that is not a safe way for us to practice.
Yep.
The problem is that back in '95, when I went to this community hospital in Northern Virginia, there were the pediatricians and the obstetricians were very involved in the hospital. Today, no hospital wants pediatricians on their staff. They don't want us. They don't have any use for us. They want the orthopedic surgeons, the cancer doctors, the neurology and the cardiologists. But pediatricians, leave. We don't care. I mean, we will put an IV on the kid, call a helicopter, send them to the children's hospital. Great, but the children's hospital can't do it anymore because they're overwhelmed and they're not getting paid because most of their revenue comes from Medicaid patients. Anyhow, so do you think we have a civic obligation to do what we are doing on the podcast, which is to re-own our narrative and let other doctors be a support to other doctors, but also to society in general, of what physicians do every day for their patients, their community? Is that a solution to shore up the workforce?
I absolutely think that we need to start speaking up together. And that's part of the hardest part of all this is that as we're driven more and more to productivity, we have less and less time to talk to each other, to reconnect with each other, because the EMR is the way it is. All of our communication is driven through the EMR to prove meaningful use. And so we're getting more and more siloed, which means we know each other less, which means we care about each other less, which is, on and on. But I do think, as a profession, I think about professionalism a lot. And I don't mean what piercings and what tattoos and what kind of dress is appropriate. What I mean is the covenant that we made to society to provide it with services it can't provide for itself. And what is that covenant that we made? And how do we maintain that commitment to our patients, to our communities that we promised as we entered this profession?
Now, I've been very negative.
Yes.
Very cynical. And I'm sorry, but this is it's a wonderful book. It's a hard book. Every chapter is wonderful, but it's a hard book.
Unfortunately, it is reality.
It is reality, and I think that's why it's so hard. The last chapter in your book you do what I love about a leader, which is to say, here's the problems. Here is my call to action. These are the things that you could do by yourself. These are the things we could do as a community to improve where we are. What are some of the solutions that you propose?
So there are so many. I think the first thing that we need to do is we need to start talking to each other, finding our coalitions that can speak out together. As clinicians, we can start educating our legislators. We can start educating our communities about the value of physician-led care. I do think that we need to start putting some pressure on the federal government in various ways. For example, the FTC, the Federal Trade Commission, is already starting to pay more attention to these things, to limit consolidation, to limit vertical integration of healthcare organizations, to limit non-compete clauses, which artificially suppress wages and keep people from moving away from places that are not good for them. We can also start asking for things like having CMS hold organizations accountable for clinician well-being, much as they take patient satisfaction into account with their levels of reimbursement. We can start doing the same for, something as simple as turnover in an organization.
Yeah. You also, I love this about the book because you're not political at all. You say the good things that the Biden administration is doing through the FTC right now in clawing back some of those mega mergers because they have not been good for society. You also give Verma a great amount of credit because even though she worked for Trump, she did simplify the number of bullets we need on a medical note in order to be able to bill for what we need to bill.
Right.
And she took away, you mentioned the book, I forget, was it like 500 measurements that were costing millions and millions of dollars to report to CMS?
I think she took away 100 and something of the 500 plus.
Yeah, and that saved a lot of money for CMS, but also decreased the burden on physicians of reporting these measures.
Right.
And that carries on in this administration too. And that's sort of what I was talking about. It's time to do away with MOC. NB Pass has an alternative that costs $200 every 2 years, and it's based on your CME, and you maintain your certification. What's not evidence-based that adds to safety or good outcomes in our patients does not need to be done.
Well, I think the other thing that we need to start asking is for our organizations. There are some big healthcare organizations out there that carry a lot of weight. And one would hope that they would be able to push back and say to CMS or to other federal organizations, state organizations, you know what? We're not going to do this because it's going to be too much work for our clinicians.
Yeah.
So there was a fairly large physician practice in Pennsylvania that got asked by the state of Pennsylvania to provide yet another report. And they actually said, no, we're not going to. You get that in 3 other ways. So you can either figure out how to collate it from those 3 other places where we give it to you, or you can decide which one of those you don't want, and we'll give you this report instead. But we're not adding one more. And the state said, oh, okay.
Yeah. The other thing that it's bothered me since I was a contract physician for the hospital, it bothered me when I was a contract physician because I got a stipend for being the chief of whatever the little Indians, because it's only 5 of us. So I was chief of a very little tribe. But it irks me when either not-for-profit, large physician organizations whose CEOs make tons of money say, well, get involved, contribute your time. My time's got value. And when I'm doing this stuff, I'm not seeing patients. You're getting a salary to do this stuff. Do your job. And the hospitals play the same game. Get on a committee. How much? I told a hospital administrator, I said, If you want the doctors to show up, put a $100 bill underneath the breakfast that you're serving because the food kind of sucks here. Oh, I can't afford that. I said, then the meeting is not valuable to you. Don't have the meeting. But it's your civic responsibility to volunteer your time for the good of society. Oh, by the way, I get paid for this.
Yeah.
Such nonsense. Anyhow, I've been too critical,
Yes, you have.
too gloom. I'm usually not this gloom. I do have a happy side. I cannot say enough. Thank you. This is a great gift to our community. It's a great gift to society. It is a wonderful read and even better narrated. It's a must for every physician. And from the bottom of my heart, I really, really thank you for having taken the time to write that book.
Why don't you repeat the title of the book?
Why don't you, George? Because you forgot.
No, if I betray these words.
If I betray these words.
Yeah.
Thank you so much. And thank you for your time today. I hope we get to meet in person sometime.
Yeah, that would be great. Thank you so much. I really appreciate it.
Thank you.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.